All right, for some reason, guys, on Zoom, it is not showing me that it's sharing. Can you see the screen?
Yes, Dr. Boli, everything good.
Sorry, it's loud. Could you
Yes,
guys chat whether or not, put in the chat whether or not you can see my screen? Oh, you can. Okay, good. Thank you, because it's not telling me that it can. All right, we'll get started then. Okay. All right, we will get started in about 20 seconds. It's nice to see you guys again. How are things? All is well. Good. That's good. Good news. Got a little snow, a little Valentine's Day fun mixed in. So hopefully not a terrible week. I hope to not make it worse, but always like to be in the classroom with you guys. So today we are going to talk about obesity and weight loss management. I'd say it is a little bit different than probably some of the other CAM-N topics, but it kind of bridges them in together in one too. But it is also a huge topic right now, and has been for a little bit, and I think is only bound to get bigger. So I want to give you guys some foundation on the topic. Disclaimer before I get started is that it is a big topic. There is also a lot of debatable language within this big topic. I'm going to teach, my slides are based from what the medical language uses right now, but understand there is a big push for change. So there may be a adaptation by the time you get to APPEs or practice. And I'm not saying I support or specifically endorse any of the language or the definitions, but they are what they are from a medical perspective right now. Okay. All right. So when you hear that topic, how do you feel like you can be incorporated into, caring for patients within these topic bundles?
Logical advice other than just take
Okay.
like exercise, foods to eat.
Yeah, definitely. Right. Non-farm is always core, even, no matter what it is, right?
Yeah, I'd say also counsel in a respectful manner what obesity can do to a person, and all the diseases that are associated with obesity, but like in a respectful manner. Also use I forgot the term, motivational interview
Yeah.
with the patient.
Right.
So.
Absolutely. Yeah, because there is, it is sensitive, but there's also important medical information, right, to relay. And so finding a way to do that in a good manner, right, in a good conversation. Perfect. Most of you guys know there are also lots of pharmacotherapy options, right? So having a little bit of knowledge to be able to do that. And so I hope today, by the end of class, anybody have any other thoughts? So my goal for today is to come back to this, Kingsley.
Yeah, I think because a lot of meditation is involved, and this person's might be another meditation, honestly, it's very important and probably patient plan. Don't therapy with interest problems, interactions, and maybe some pharmacogenomics, because not everybody react same way to the same medication. For the pharmacogenomics now, because of the way the data are, that I do think is good.
Yeah. Yep, very great points and some of the key therapeutic options. So awesome. I hope that by the time we're done today, you also have sort of expanded perspective on ways that we can also, be of value and importance within this realm. Let's start off with some definitions. Okay, so generally, obesity is defined as an increase in size, an amount of fat cells in the body. So it is specific to, the component of fat. There's designations for abnormal and excessive, and they correlate with the terms overweight versus obese in terms of the degree of that excess fat. So these definitions or distinctions at this point are really made based on the calculation of something called the body mass index, which you've probably all heard before. And that takes into account patients' height and weight. As most of us probably inherently recognize, these are surrogate markers of adiposity, right, or fat. There are more parts of our body that contribute to our overall body weight than fat. And that's the biggest argument, right, against the current definitions that we have. But for now, the BMI is our screening tool. And then looking at the BMI scales that correlate with kind of the terms, we can further subclassify obesity into class 1, 2, and 3 as well. And you'll see some of these designations like in the studies or in indications for different managements and things like that. One thing that I don't want to overlook, though, is a key at the end of that top definition in that presents a health risk. So it's not simply numerical or about a number of on the scale or this BMI index. This is a core health component because at some point that additional or excess fat accumulation does, as Ernesto mentioned at the beginning, right, impose a lot of other challenges on other diseases as well. So that's a big crux of the definition, and what is really the target when we're managing these conditions, right? It's not really, again, about the weight loss number, but are we improving their health? Are we reducing their risk of these other disease states or overall risk of mortality related to those? A little bit of just kind of epidemiological data. I don't think any of this will come to a surprise. But as of like the last survey, it's estimated about 1 in 3 adults are overweight. 2 in 5 are classified as having obese. And childhood obesity even is estimated to be about 20%. So, and all of these are projected to continue to rise, at least as of where we are now. But we'll see, because like I said, the industry at the moment is quite a hot one. I also want to offer a glimmer of hope in that, again, there is a strong coalition that are really aiming to do away with BMI figures and figure out a kind of a more robust and more realistic way to help identify those that really are at risk for those health effects. So obesity really is considered a chronic disease state. And you should talk about it and treat it like any other chronic condition.
It's like, I've heard that obesity is like an inflammatory state of the body.
It is.
Oh,
Yeah, well, it's like, or that the inflammation secondary to the fat accumulation is a lot of like the crux of what is happening kind of like pathophysiologically. And that is specifically is what leads to like all the like the downstream sequelae. So that's exactly it. It's basically a chronic low grade state of inflammation. And we know that inflammation takes its toll, right, on our bodies because we have these signaling cascades that are always going off, a lot of unwanted effects of inflammation, and in states of continuous inflammation, it impairs our immune systems as well. And so that's a lot of the basis of the kind of the pathophysiologically there. It is associated with pretty much diseases of every organ system, heart, lungs, liver, kidneys, like everything is correlated in terms of having additional risks when fat accumulation is present. One of the most significant, and you see all over the literature, is correlation with cardiovascular disease. So we know cardiovascular disease is the number one killer, right? And obesity is kind of a direct pathway to that. You can see some of the numbers here. I think, they do try to classify the mortality numbers itself, and obesity is sort of labeled as the second leading killer of preventable disease. So things that you can actually modify and reduce your risk, only to one thing. Do you know what the number one prevention that you can do to just improve your chances of living? I don't think I've heard it yet. Smoking. So not smoking. Okay. So, and all that, I'm sure the remarks that you guys had are up there as well, but that's kind of how it's all correlated there. So, the etiology is, as we know, is multifactorial. Right. So these are some of the major players. Our genetics, dictate a lot about our overall body mass, our hormones, our bone structures, things like that, and our fat distribution. Environment. What are some things in our environment that have probably had a play in, the rising epidemiology? Yep, fast food, supersizing, advertising, right? All of those things. Cost, right? What's cheaper to buy? Going to Whole Foods and buying like a nice whatever salad, or your $2 2 for $2 at McDonald's. So I get it, in the setting of inflation and all of these other things, right? So culture-wise, so they're just different, socioeconomic beliefs, different religious beliefs, all of those things are going to fall into play. Medical conditions, right? There are lots of medical conditions that alter body composition. Some of the most direct ones, like these conditions lead specifically to fat accumulation. Does anybody know of those? Cushing's disease is the one that comes to my mind, and actually talked to you guys about Cushing's in a couple of weeks in 420. But yeah, so when you think about like buffalo humps and the big puffy cheeks and things like that, it's like a direct connection with the disease state itself. And then of course we have, did you have questions?
Say like, if they like certain medications like prednisone, I think makes you like, I don't know if it's a water retention. I have a friend who started like her therapy and in some way she was a little bit frustrated and the doctor told her.
Yeah, absolutely. And we're gonna see that drug on the next slide or so. And actually, steroids kind of create a form of Cushing. So it's, it's kind of like similar physiology, pathophysiology there. So yeah, so of this list, again, as pharmacists, one thing that we can be cognizant and educated about, right, are medications that are associated with weight gain and increased fat accumulation there. And so here is a non-comprehensive list, but some of the most common, and I liked this chart because it actually did give a little bit of a range of like what the expected weight gain is when starting these for a lot of patients. What catches your eye on this chart? Yes, so on a NAPLEX, on a multiple choice question, if you're asked about weight gain and given a choice with an antipsychotic, that's probably your biggest offender. Some of these meds, like olanzapine, they've been like directly, and not just weight gain, but then that leads into diabetes and other conditions as well. So they are definitely top of my head. But lots of other ones too, like a lot of our serotonergic, depression and anxiety meds, as Ernesto had said, steroids are well known with another considerable, quantity there, and there are several mechanisms for that as well. Both water and kind of fat gain for different reasons. And we'll, I think, go into that a little bit when you're going to talk about steroids every day for like the rest of your life. When we hit like the immune part of your 420 module. So you'll learn a lot more about steroids there. Uh-huh.
Why like antipsychotics are like, is it because like you are dealing with maybe like some receptors in the brain with hunger and you are more hungry and eat, or is it like directly acting in the metabolism, or
That is a great question. It's probably multifactorial. It has been a while since I've like looked into the specific mechanisms of those. It doesn't, I'm sure receptors have some component of it, but it's not like it's not fully it's not a full class effect. So there are individual things about like certain drugs as well that puts them higher on the list. So I wish I could be more articulate, but I think it's multifactorial because of that. Yeah. So kind of keeping some of these in mind, and hopefully as you get to these areas of PT too, you'll be able to describe it better than I can today. Yeah. As Jess had mentioned, let's talk non-farm. Let's always start there, right? AKA lifestyle therapy, things that all of us should be doing regardless of our BMI, right, is, looking at our calorie intake, making sure that we're maintaining physical activity. Specifically though, when you are trying to achieve a weight loss, generally you need to look and count at that calorie intake and expenditure, and a recommended deficit between 500 and 750 is what is recommended per day. Physical activity, technically per the guidelines, they say 150 minutes per week at minimum. So how you get there is, you figure that out with your own lifestyle, but they do specifically articulate resistance training as part of that. So not all cardio some resistance training too. And then behavioral modification really includes, that's multifactorial too. Nutrition counseling, any other condition that is affecting, your ability to do these other lifestyle interventions like mental health challenges and things like that is all kind of bundled up in there. Kings.
For a person, we all have different amount of food that we eat. Is it going to be person specific?
Yes.
It
Usually you are supposed to calculate an individual like plan, but it generally averages out to somewhere in that area. The bottom line is you have to expend more than you intake, but you can't overshoot or otherwise that slows your metabolism. So it's personalizable for sure. But that's just kind of like the ballpark. And the general concept again is more you need to be in a deficit, right? To lose weight, you need to be in a deficit. Some additional non-pharmacological interventions. So there are a number of medical devices that are, these actually have to go through the FDA. These get really interesting here. Different modalities to address weight loss. You can see some sort of a neurohormonal, some are actual physical, like physical devices. Probably the most well-known is the balloon, the gastric balloon, which simply it is a balloon inserted in your stomach that is then blown up and it just takes up space, right? That food can't. There are also, this was very interesting that I read, there was not just in your stomach, but actually oral. There's a device that you can put in your mouth that causes you to only be able to chew very small amounts of food at one time. And that slowed eating also then lends to weight loss and you feel fuller faster. So I thought that was interesting. We're going to talk a little bit about hydrogels. But again, it's always fun to learn what you don't know, right? This was a device, the Aspire Assist device. As it looks like, probably you can tell from the picture, is that it's a little tube that's placed into the wall of this skin in the abdomen that lands into the stomach. And anybody want to guess what comes next here? Like, I was like, oh my God, this was a thing. So you eat, right? And then 20 to 30 minutes after you eat, you attach this little device here. And you basically, I don't know how it works, if it's a vacuum or whatnot, but it essentially sucks out, I don't know, 50 or more % of what you just ate into the bag, and then you dump the bag into the toilet. This is actually withdrawn for the manufacturer, probably after a lot of backlash, as you can imagine, but it existed on the market and was FDA approved for 6 years. So things are wild, like literally wild. Yeah. With that said, another big, I would say that I don't think beyond the balloons that the devices are widely popular, but bariatric surgery is another means of weight loss. And this, I think the direction things are heading, hopefully is to replace this term with metabolic surgery. But for the most part now, bariatric is your key search word to find what you're looking for. But this is definitely a rapidly growing elective what's now currently considered elective surgical procedure. And it does remain the most effective intervention of anything that we'll talk about today for weight loss. So it's I guess on average, about 40% of, body weight is reduced through surgery and, is long lasting. So it's kind of like the longest, sustained effect. Again, out of all of our options here. You can see like there are a lot of components for candidacy. So there just are straightforward BMI stipulations that you can see here. So the guidelines support only if the patient has a BMI greater than 35 or 30 plus with some kind of pre-existing metabolic disease. So that's the target, kind of the target BMI definitions. Of course, they want you to go and exhaust, less invasive options. You need a mental health clearance because it is a lifelong commitment after these surgeries to comply. And many facets of daily life are changed by these surgeries. Of course, you need general medical clearance to undergo any kind of surgical procedure. So you need to get those pre-ops done. And a lot of times there are additional stipulations as well, like the patient has to demonstrate some weight loss on their own, they can't be smoking, like they have to take care of some of the other modifiable factors as well. If you're interested, there are some surgical guidelines to follow as well. That's kind of beyond the direct pharmacy scope, but interesting. And although it's growing, though, there's still it's considered to be the most underutilized option, given how efficacious it is in comparison to how many people actually go forward with it. But to be honest, like in my clinical practice, like every year I see more and more patients undergoing bariatric surgeries. Yes.
How affordable are all these procedures accessible to the population that has obesity? So if they are not affordable, then are we really solving any problem?
So my understanding is that from an affordability standpoint, insurances are more likely to cover these than like some of the medications that we'll talk about, for example. I don't know why it's stipulated differently per se. So affordability is not perceived to be the major barrier. It's either fear, I don't know, like probably multifactorial, fear, commitment. Yeah. But in theory, there's opportunity. It's not like just the elite independent insurances and and things like that. So there are sort of two mechanisms by which the different types of surgeries are classified in terms of how they do promote the weight loss. So a restrictive procedure is one that achieves weight loss by limiting the intake of calories. And that's pretty much due to allowing a smaller volume of food to even be ingested. And then malabsorptive is alteration of the intestinal tract to bypass a part of the gut that is going to, be absorbed. And so more gets eliminated. And, the less fat you absorb, right, the less that's going to hang out in your body. And the procedures can be one, the other, or both. They're not, so some can be both. And obviously, when you combine the two mechanisms, generally you're going to see a larger effect.
Really?
Yes.
If you would like to absorb it, this procedure, you have to do some consideration when you're taking some medications orally.
Absolutely. And we are going to talk a lot about that. Yep. We were going to get there. So that is why, not that we're surgeons, but that is why I think a bare minimum understanding of the 4 different procedures can be helpful. So quickly, just kind of running through the 4 procedures that are done now in the United States. So gastric banding, or I should say both of these are laparoscopic. Do you guys know what that means?
Sort of device, the camera.
Yeah, so like non-invasive or minimally invasive, where basically things are done through small tubes that are inserted in different places of the body to examine or operate in a given area. These are generally, yeah, nothing's being opened, right? There's no cutting. So things like that. So both of these are laparoscopic. Banding is like it sounds, an adjustable band is placed around the top of the stomach to create a small pouch. And because of the pressure and kind of the change in the anatomy, the overall volume is decreased and people feel fuller, smaller. Some of the advantages here, and this would be a restrictive one, right? So this is limiting the amount of food intake. So positives here is that it's adjustable or it's removable. It's not permanent. The disadvantage is because it's so easy and it's has probably the lowest efficacy of the 4 different procedures. And also these bands can shift, move, erode through the actual stomach lining. So, it does require monitoring for those factors. The sleeve gastrectomy, have you guys heard of that before? Or gastric sleeve? This is actually the most common in the United States. So you may see this in a lot of like your patients' past medical histories. This is definitely more permanent, right? It's not just a band, but this whole area, banana-shaped area here, which is the fundus, is actually cut and removed from the patient's body. So obviously their stomach is now significantly smaller, right, in surface area. So also a restrictive type of operation here. A secondary effect is also an effect on one of the hormones called ghrelin. This is one of the hormones that we believe has a lot to do with hunger and satiety. And so reducing that is like a secondary mechanism here. So yeah, so more risky and permanent, right? But also more efficacious. So that's kind of your pros and cons there. These next 2 get a little bit more complicated. Anybody heard of a Roux-en-Y? So this is kind of the second most common. And actually sometimes this can be like as a follow-up to the sleeve. So there's multiple steps in the surgery. Sometimes it's laparoscopic, but sometimes it does need to be open abdomen surgery. Both of these are both restrictive and malabsorptive. And so the efficacy is going to be higher, but again, they're going to come at a cost. So the Roux-en-Y first reduces the overall size of the stomach, and then it basically forms a bypass to the small intestine to further inhibit the absorption. So the restrictive part is the first step of the making it smaller, and then the bypass makes it malabsorptive. This is again a lot more effective and can again be a follow-up. I just had a patient actually that I saw last week that had a sleeve in like 2014 and then wound up having to convert that to a Roux-en-Y last year. So that does happen. This is the most complicated. Don't really need to focus on that, but it's another kind of multimodal approach. And this is really reserved for like the highest BMI patients. It doesn't have to. I think you can just go straight into the Roux-en-Y. Yeah.
happens by digestion or happens in the stomach. The stomach is bypassed, that was digested.
Not fully, but a lot of it, a lot of the absorption is reduced because it's small, I can't, what's the word? It's reduced. And then other parts are kind of rerouted altogether, like. So it is interesting. So I don't, probably as you can imagine, just kind of seeing what some of those look like. And also all of these are hyperlinked. So if you are interested and want to learn more about the procedures, you can click on those links there. So there are a number of consequences, and I guess to the point earlier, a lot of the fear factors that go into why patients may not even consider this. Not saying this always happens, and this list is like just collective. Not every procedure has all of these risks, so you really have to look at them individually and counsel individually. But there are a lot of scary things on this list, so it's understandable why it just might be too much for patients to kind of look at. Just for definition's sake, I think a lot of these are things that you'll understand. Gastric prolapse. So do you guys know what the word term prolapse means?
Place.
Yeah, getting out of place and basically protruding onto some other organ. So you can have lots of different kinds of prolapses, rectal prolapse, like that, like when your inner rectum starts coming out. So this is like portion of the stomach protruding into something else that it doesn't normally touch. Gallstones, do you guys know what gallstones are? Hopefully none of you know by personal experience. As I've literally heard, it's worse than childbirth, but these are basically just collections of cholesterol deposits that form and can be very irritating, but then can move too and like lodge in places where it doesn't belong. Fistulas, kind of similar to prolapse. Do you know what a fistula? Yeah, exactly. So basically a fistula is a connection between two things that don't normally connect. Sometimes we surgeons form fistulas intentionally. You'll learn in hemodialysis, a fistula is a surgical procedure that some people get to be able to be dialyzed. And so they're forming connections between arteries and veins. But also fistulas happen naturally that shouldn't happen. So this would be one of those. Yeah, so something in the gut connects somewhere else. And as you can imagine, this gets really crazy. For example, like if you have a waste organ and that waste organ now has a conduit to somewhere else in your body, it's going to contaminate everything else. So fistulas can be super dangerous. And then dumping syndrome is where things is common in post-bariatric surgery, and where things just food moves so quickly through the stomach into the intestines that like things are getting to your small intestine like non-digested, and that can cause a lot of issue, like a lot of symptoms, a lot of side effects and discomfort, but also shifts in like your blood glucose levels and your hormone responses and things like that. So it's a pretty big deal. Not on this list, but as Ernesto alluded to, another complication and the biggest one to impact us is going to be how it subsequently affects the medications that a patient is taking. Okay. So what does that mean? Dun, dun, dun. It means we use our expertise in pharmacokinetics, which I know scares many of you. But this is why I like to jump on this lecture, because I like to talk about kinetics whenever I can. And so the next few slides are going to directly jog your brain in terms of pharmacokinetics. Okay, and once again, these are collective. It doesn't mean every type of surgery has all of these effects. You have to know the surgery that your patient had and then know that surgery specific effects. And there's lots of resources that I posted on Canvas that, should you need to go to that level of detail, are there for you. So just in general, okay, so we have ADME principles, right? A for absorption. So these are four parameters of absorption that can be altered as a result of bariatric surgery. Who can guess as to any of, well, let's go in order because the first one's probably the easiest, right? So what do you think happens to surface area as a result of okay, so yes, heard that loud and clear, right? So the, for the most part, they all have some capacity of reduced surface area of the stomach and or the small intestine. What does that mean?
Absorption is not gonna be so effective.
Yeah. So less surface area means less place, right, for medications to be absorbed there. So, in our gut, obviously, most of the medications that people take are oral meds, right? So they do require absorption through the gastric mucosa. So we're going to see that. Less, like maybe less thoughtfully, or this wouldn't be your primary thought, but also within the surface area itself, remember that we have lots of transport proteins along our mucosa that also influence absorption of drugs. And so those are going to be bypassed as well, for an overall decrease there. Thoughts on what happens to pH, or just like how pH affects absorption? What was that? Increased pH? Yeah, this one's kind of tricky. Where are the cells where are a lot of cells in our body that secrete acid? In the stomach, right? So if we cut the stomach out, right, or band it off so that it's not accessible, that's going to be less acid produced, right? And so a reduced production of acid will raise the pH, right? Because those are inversely correlated. And how does that impact drugs? Right, exactly. So there are many drugs that have a preference for either acidic or alkaline environments. So if a patient is on a drug that really liked that acidic environment and now it's no longer the same low pH, it's not going to get absorbed as well. On the flip side, if something is strongly preference for alkaline, is maybe it gets absorbed better than it did before the procedure. So medications have certain preferences. A rise in pH means there's going to be a more alkaline environment, and it's going to decrease the absorption of those acid preferring agents. And typically the drugs that are absorbed in the stomach are those that like acid, right? That's how they were developed, knowing that the stomach has a low pH. Even some of like the enteric part of like enteric coding, right, has to do with finding the right pH and things to do. So it can affect a lot of those. Gastric motility, this was a tough one. So it can sometimes go either way. You guys have heard of the pyloric sphincter. Does that sound semi-familiar? Yes, because you just got out of, right? You just got out of this. So this is something that's very impactful for kind of the propulsion and gastric movement. So if the pylorus is affected by the surgical procedure, there's definitely going to be some changes there. And again, if it's a smaller tract, right, or if it's a diverted tract, things are going to move differently than they would otherwise. So it's harder to say exactly how that affects drugs because there's a lot of different scenarios, but just kind of thinking in general that motility and gastric emptying can be affected. So what do you guys think about like time-released medications? It's going to be time-released medications, right? So if a med is specifically designed to release at a certain rate, right? And then the gastric rate is sped up in that patient, it's not going to be absorbed, right? Or the same quantity, the same amount will not be absorbed. So lots to think about there. And then lastly, bile acids, bile salts can be really important just to assist in medication dissolution. So again, you're cutting off areas where bile salts are normally produced and mixed in the GI tract. And so some of that dissolution can be impaired there. So got it. Take your pictures. I'll give you a second. Okay. All right. What's next? Distribution. Not as specific, not as many things affected here. Kingsley.
In case of that, thinking about the violence of the small intestine, what is happening with this program, why is it affecting it?
Say the beginning of the question again.
The bile release is happening in the small intestine. And this surgery is in the stomach. So why is it affecting?
Well, so some of the surgeries do alter some of like especially the proximal small intestine as well. So that can be impacted. Not all of them will, but if it does impact the small intestine, then that has more of an effect with the bile salts. Okay, so distribution or volume of distribution, what does this mean to you? Yeah, like, right, so where systemically does it go, right? And so volume of distribution is definitely influenced by degree of adiposity or how much adipose is there. And so how might, again, kind of drug characteristics be affected here? What do you guys think? What was that? Lipophilic drugs are going to be probably the most affected, right? Because you are changing, right, the overall degree or making the adipose compartments less or smaller, right? So that will overall decrease the volume of distribution of lipophilic drugs. Okay, does that make sense? Lipophilic drugs have the characteristics to distribute and preferentially distribute into adipose. You reduce the amount of adipose, so you're going to get less tissue distribution, right? And when it doesn't go into the tissues, where is it going to go? Blood, right? It's going to stay in the central compartment. And so what does that mean clinically? Yeah, right? Be brave, Jeffy. Yeah, so right, so if you have a lower than normal volume of distribution, your blood levels are going to be higher than they were before you removed all the adipose, right? And so either you're going to have, if you do not dose reduce, you will likely experience toxicity, right? Because you're going to have a rise in the concentrations of whatever that drug is in the body. And so, understanding some of the drugs, there are just some well-known, verapamil, diltiazem, or some of like the very lipophilic drugs that will need to change. Metabolism. So where does most of the metabolism happen in our bodies? In the liver. So this is not a primary, or this is not as significant, but there is some metabolism that does happen in our intestines as well. So it's not just our liver. So again, if part of that intestine is removed or bypassed, right, metabolism that previously occurred within that area is going to be decreased. And the biggest effect when we see these, changes in metabolism is what's known as the first pass effect. So again, what does that mean to you? What's first pass metabolism mean?
Pass around the liver, and specific enzymes converting the drug. So if you have a prodrug, I guess it's not gonna be as well as absorbed if you have like increased your first pass metabolism.
Correct. Yep. So for the goal, what's the goal of first pass metabolism?
Convert one to make the drug more hydrophilic so it can be eliminated.
Right, exactly. And that's a protective mechanism, right, that our bodies have, is that our liver primarily, but our small intestine secondarily, are going to take a look and evaluate what this thing is that just came in the patient's gut, right? Change it to make it safe or able to be eliminated. And then go into the systemic circulation, right? So before it can spread out through our body, it's like this check, right? It's like this safety check. But also things happen, so for most drugs, metabolism reduces the systemic exposure, right? So most of the time, metabolism will reduce the amount of drug that the rest of our body sees. Ernesto brought up the exception, right, which is a prodrug. What is a prodrug? Yeah, so it needs to be activated by metabolic enzymes, right, in order to have an effect. So that's the opposite situation, whereas if the prodrug isn't metabolized, it will never do anything, right? So understanding, the differences between prodrugs and regular drugs or non-prodrugs will have an effect, kind of that are opposite depending on the situation there. But overall, a small potential decline in the metabolism there, okay? So once again, so this at the bottom, not prodrugs, everything but prodrugs, right? But if you have a reduced first pass metabolism, you're going to have a higher than normal systemic exposure to the drug, which is the AUC. And once again, you would respond by adjusting the dose, or the patient's going to experience additional toxicities. Okay. And then lastly, there's also some kind of mucosa that has some additional metabolic effects. If you remember, there's also beyond CYP, there are some other transporter proteins and things that interplay with metabolism. Good. Okay. All right. So with all of that said, have some sort of like capstone considerations for how to go about, evaluating a patient's medications after bariatric surgery. So one thing that is pretty common is to consider changing in certain dosage forms. If there is a more reliable mode of administration, you can make those changes. One definite thing you want to do is look for any extended or time-released medications, right? Because those are going to be significantly impacted by the changes. So anything that you can alter to immediate release is ideal. Substituting, again, things that are known to undergo significant first pass metabolism because they're going to be affected the most. Not so much pharmacokinetic, but more pharmacodynamic. Anything that further irritates the mucosa or that can, make it more friable or angry, like NSAIDs is advised. And then one thing that like every article you read about reminding people post-bariatric surgery is that contraception can be impacted, whereby the estrogen containing medications can have both a decreased efficacy, but also contribute to like compounding toxicities as well. Other things to consider that these weight loss surgeries, these bariatric surgeries are very effective. And again, not targeting, they will decrease weight, but what they will also do is help get the disease states, like those metabolic disease states, under better control because of the reduced adipose. So patients with high blood pressure, high cholesterol, diabetes, you should anticipate seeing those conditions improve. Okay, so what does that mean for their insulin? You probably need to reduce it, right? Same thing for blood pressure meds and so on. Also within that sort of contraception, I don't know the mechanism, but fertility is increased with this. Probably, I guess, the immunosuppressant effect. GERD sometimes can improve and sometimes can worsen. GERD's a funky one. So just kind of thinking about those. And then, the weight changes can have an effect on patients' mental health conditions as well. Also huge is that a lot of these surgeries come with nutrient deficiencies. Very, very prime, like immediately following surgery, but there's going to be some lifelong nutrient deficiencies as well. And so polypharmacy becomes an issue for sure. Oh, I didn't mean to do this that way. Okay. Okay, I'll just put them all up. All right, so looking at these one at a time, having considered all those things that we just talked about, what is your concern with warfarin or Coumadin? Okay, so bleeding in that surgery in general, right, puts the patient at an increased risk of bleeding, as would the anticoagulant. Any other thoughts? What was that, George? Concentrations of the drug? Oh, so like what immediately comes, like in general, comes to your mind, about these drugs? Like if a patient who just had bariatric surgery, let's say just had Roux-en-Y, right? We're on these drugs. What would you be worried about, or what do you want to think about? What was that? We'll talk, not with this particular one, but, good try, good thought, that's okay.
Say, warfarin, maybe since you have all those peaking parameters to see if that dose is effective, or you have to reduce or increase the dose depending on the INR of the patient.
Yeah, good. How do we, along those lines, like critical dosing, what term can we give to medications like warfarin? Yeah. So that's what I was kind of hoping you would get to. So, right. So, warfarin as an example of a narrow therapeutic index drug, those are going to be your trickiest and most vulnerable medications, right? Because they have a small window of drug concentration, between efficacious and toxic, right? So that's definitely something to consider. The fortunate thing in warfarin is that you can adjust, right? We have lots of different dosages that you can get to. So that's what I was getting at there. Warfarin also has a lot of smaller complexity, so I could go into detail on that, but I'm not going to. I wanted to hit home the point of narrow therapeutic index. What about the citracal? Mhm. Usually, but not across the board. So not across the board. So absorption can be reduced. What is one question you would want to ask yourself? Like, because this is what I do when I have these patients, and this is one of the most common consults that I get from physicians is, can you go, my patient just had Roux-en-Y, can you go through their meds and tell me what they can't be on anymore? Or what doses we need to adjust. What do you think is one of the most critical questions that you would have to answer for every single individual drug related to what you asked, Kingsley? Yep. So even before that, Ernesto, did you have an idea? That's one of them. Like what pH, what's its pH sensitivity? I would say the first question that I'm looking for is where is the drug normally absorbed, right? And so you have to compare that to what anatomically changed based on what specific surgery the patient had. And so if you're dealing with a drug that is predominantly normally absorbed in the stomach and their stomach was just 80% removed, that's a big deal, right? But if you have a drug that is predominantly absorbed in the small intestine and their small intestine is intact, then it's not that big of a deal. Does that make sense? So it's very individualized. And I just want to teach you some of the things you need to think about, but not every rule or process is going to be applicable for every drug or every patient. So it's drug specific, it's surgery specific. And then you kind of have to go in depth into their kinetics. Uh-huh.
Which might be important for absorption of
Mhm. So it depends, because then you have to factor in this steps beyond absorption. So like as a caveat, let's say they absorbed less drug than normal, but the drug that they absorbed wasn't metabolized like normal. So does that make sense? So that it's like you lose drug, but then you gain it back because of an alteration in the metabolism. Does that make sense? So it's just very, I can't get much more specific than it depends on the specific drug and the surgery. Understanding the principles and how things influence the drugs is where I want you guys to be. Okay. All right, Citracal. Any thoughts? I tried to pick the picture where like it's a really big pill, right? There's nothing too specific to the calcium or whatnot, but it's just a really big pill. And you know, considering the banding or the size of the anatomy, it might not be so pleasant for patients. Mhm.
It's like sustained release, so.
Yeah, perfect. Perfect, right. So specifically, I didn't just put Wellbutrin in general. I put the picture of the SR version, right? So this is a drug that is specifically developed to have its kinetics influenced by the way that it's, you know, designed. So an SR, any SR drug, right, will probably look different in terms of its systemic levels after certain gastric surgeries, right? Because it's just going to release differently and in different places than it normally might.
And are there like studies in like or guidelines to how you would dose this patient?
Not many. So you have to like look up what, sometimes there are some like in vitro studies and some guesses, but most of the time it's like clinical, like what you think. Yeah, I should probably try to make like an article, a review article. That'd be very popular, but there are a couple of review articles, but they don't hit everything. Like I usually individually PubMed search every single drug is what I do. Last one, prescription for morphine sulfate. There, any thoughts? Yeah, so certainly, it honestly could go either way, to Kingsley's point. So, you could look at it at potentially impaired absorption, and that could lead to a reduced, you know, pain effect, right? This is just not, you not need to memorize what morphine does, but morphine I use as an example of a drug that does have a high first pass metabolic effect. And so if that doesn't happen, right, if first pass metabolism is reduced for this drug, and again, higher systemic concentrations are seen, what's the potential effect? Somewhere along the lines of sedation to respiratory compromise, right, to death, right? Everybody follow? Yes. All right, lastly, before we break, the second part is much faster. These just kind of go through the fact that, again, there are lots of, the whole concept of the malabsorptive surgeries is reduced absorption. So that's not only of fat, but of other important nutrients. So if these are some of the nutrients that our bodies need that are likely to be reduced post-bariatric surgery. And so most patients will need some form of supplementation of these. So remember, B12 is associated with anemia. You just learned that, right? And folate, just learn that. And thiamine, look at that. All connecting the dots here. Calcium, vitamin D, often needs supplementation, and your fat soluble vitamins, right? Because I guess that's more intuitive. So this is just an example. It's a patients immediately post-op have a crazy supplementation schedule. So this is just an example of one, how they have to separate the doses, take them in small bites. So they're like dosing, multiple times a day between multivitamins and calciums, irons, and things like that. So it's very rigorous. All right, questions? I mean, some things can be adjusted based on timing, but some things are like permanent changes in their body. So yeah, no, that's the first thing that you can do. If there's a more reliable way, like for example, my patients with HIV, we try to get them on injectables. Yeah, but not everything has a patch or, an injectable or something like that. All right, 320, did you guys? What do we go? That's on 350, right? Okay.
I just found my new thing. What do you, I would take that, are they soft? Soft versus. Oh, yeah, does it say salt? Dr. Paul, would have a problem with that.
I don't like medium, I'm not.
Oh, wait. I just took.
One time.
I'm 95% sure.
No, she had the, like, they like, I think I get a
No,
lot.
she had more than just that.
Yeah, when it's honest.
All right, so I want to make a quick clarification, based on a great question that came up. Just to clarify the timeline a little bit better on some of the kinetic changes. So factors changed from an absorption standpoint are going to be pretty immediate after the surgery, right? Because of the anatomical manipulation. With regards to adiposity and distribution, you don't come out of surgery weighing, 40% less of your body weight, right? That is a more gradual loss, and so change over time. But in general, you want to keep that in mind, right? As over time, you need to be thinking about the lipophilicity of any drugs and how that might, that distribution may start to be reduced over time. I've seen a lot of variation in terms of the weight loss, in terms of how much, how fast, what the pace is. So again, a lot of it comes down to that individualization, but absorption, pretty immediate, metabolism, pretty immediate. The distribution is more of a long-term effect. And then also just to clarify, what ADME did we miss? Elimination or excretion. So that one is not really impacted much by bariatric surgery, except there's kind of one situation. Can anybody think potentially, yeah, if something is excreted through the bile? That's a good one. I wasn't thinking about that. The thing that comes to my mind is if a patient is having renal or kidney impairment as a consequence of being obese, and that resolves, right? The kidney function improves with the weight loss, then renal elimination may improve in comparison to pre-surgery. Does that make sense? But it's not considered to be major. Okay. So now probably getting to the point where you are expecting to talk about today. Non-pharmacokinetic is more about the patients that do not go, through bariatric surgery, or not yet, but are trialing pharmacological agents. So all of these are going to be considered to be adjuncts, right, to the lifestyle interventions. So in addition to all of those non-pharms that we talked, or the basic non-pharms, they may each carry a little bit different indications, but for the most part, they're going to be indicated for patients who have a BMI similar to the surgery, right? It had different criteria, a BMI of at least 30 or a lower BMI with a comorbidity. Okay, so generally this is a common, kind of a common condition for use. A couple of general principles here. So again, obesity is a chronic condition. It's going to be a lifelong thing that that patients have to be considerate of. Most of the medications try to target the neurohormonal dysregulation, not an attack on like the adipose cells themselves or something like that. Treatments are only going to be, FDA approved if they do show not just BMI change, but also comorbidity change. Selection, it should always be based on the individual. And there, is a lot of heterogeneity, meaning not everybody responds to, to some medications, or everybody can respond very differently. So that gets tough. To George's earlier question in terms of access, the last statistic I saw here is that fewer than 1 in 5 insurances will even cover weight loss pharmacotherapy. So that has been a huge, barrier in the past, though we're slowly starting to break that down. And if you're like me, I've seen a boom literally just in the past year alone. So probably getting bigger. This is an extra slide. You don't need to know this. It's just to kind of start off the context in that there's a lot of emotion, like a lot of perceptions, some stigma, all of these things revolve heavily around weight loss pharmacotherapies. I think a big part of that, especially on the part of providers or prescribers, is that there have been so many historical failures in this treatment arena before that they get nervous. And it's like it takes longer for them to believe or trust in the medications. So all of these were prior drugs that were used or studied for weight loss management, and look at some of the reasons why they are no longer. These aren't like, caused GI discomfort, right? It's like caused cancer, caused myocardial infarctions. So I think there's a very good reason why this is just such a unique space, and there's a lot of hesitancy. With that said, these are the list of the currently approved FDA agents. I did throw in one of these devices in here. It looks like a drug, but it is a device, so we'll talk about that one. You've probably seen a lot of these, I would suspect. That while they are all FDA approved, they're not all guideline endorsed, so just keep that in mind. So I just wanted to highlight a few things about some of them. So Q-Cinia, seen that? Yes, usually this, yeah, this is, is pretty common. So starting with the orals, this is one of them. It's a combination of phentermine and topiramate. So phentermine is actually even on its own, like you might say Adipex, right? Or it has another name too, but so it is a sympathomimetic. And sympathomimetic in general has appetite suppressant effects. So there are other like amphetamines too will have a similar effect. And then so again, it can be on its own, but more recently it was paired with topiramate. When studying for top 200, you may have remembered weight loss is a sort of a side effect of topiramate. And I think that was extrapolated a little bit here. We don't really know why it causes weight loss. Probably has something to do with its GABA effects. But what we do know is when we do combine it, you can give less phentermine, which is helpful because then you have less of the unwanted alpha adrenergic effects there. And so thinking about, what you have in that combination, it should make sense. Topiramate is used for what are some things used topiramate for by itself? Oh. Different things. So originally anticonvulsant, okay, its primary use is an anticonvulsant. But many people also use it for migraine prophylaxis. Okay, so for an example, if somebody had migraines and wanted weight loss, this might be an opportune combination for them. On the flip side, you have to be really careful with phentermine. So people who have cardiovascular risk, uncontrolled blood pressure at baseline, things like that, you probably don't want to give a sympathomimetic to, okay? So it's really breaking down the individual components, trying to figure out who things are safe with. The other factor though is topiramate is also teratogenic. So you need to watch your population and counseling, contraception, and things like that. Contrave, who's seen this one? Not as much, a little bit, but not as much as Qsymia. All right, getting a mix here. So this is a combination of naltrexone and bupropion. So let's break that down. What is naltrexone?
Opioid.
It's an opioid agonist, yep. What do we usually use it? We don't usually use it for pain, but what do we usually use it for? Yeah, relapse withdrawal, right? Management of either alcohol or opiate use disorder, so to prevent withdrawal. But it's also thought to have some effects on the hypothalamus, which, again, is part of the physiological cascade. And then bupropion, antidepressant, perfect. And smoking cessation aid, right? So once again, if there's potential dual uses, you can consider that as a positive variable. From a safety perspective, which part has the seizure warning? The seizure warning comes from the bupropion part. Naltrexone by itself is does nothing. It's no sense. But other than, I don't think it's up here, but oh no, it is up here. Why should we not use it concomitantly with opioids? Right, it's not an antagonist, but what's it going to do? It's kind of going to work as an antagonist because yeah, it'll compete, right? So it'll probably put them into withdrawal perspective. So these are some things to think about. Orlistat is both a prescription and OTC product, depending on the dose. So Ally is over the counter. Xenical is prescription only. I hope you don't see this, but it is still available. The guidelines specifically recommend against this. So it's not like they say for or against everything, but they specifically say against Orlistat. This works by basically preventing the absorption of fat. So you take it with meals and it'll try to block the fat absorption from that meal. Where do you think the fat is going to go if it's not absorbed? In the stool. So yeah, so you're going to poop out these very oily, fatty, stools, and they're gonna come on abruptly, and you're gonna leak, and yeah, so it's a lot. So I personally would try to avoid any kind of counseling for this, and I would try to avoid anybody that was trying to purchase this from taking it, but it is available to them, particularly without a prescription. Did you have a question? Oh, Ally is over the counter. Yes. This is one that's just kind of in here for completion. It's a very special population niche drug. You can see it's approved for this rare genetic disorder. But this is like one of the ones that have, it's very different mechanism. So I don't know, you probably won't see this, but technically it does exist, for that specific indication. Now to the big guns, right? And so ending on our GLP-1s, right, which are everything these days, I think. So Wegovy is the branded name of semaglutide for weight loss. Okay. Its sister or brother, whatever, is, do you know, Ozempic for diabetes. So this is, you'll learn more about these in the endocrine module, but these really, this specifically really was a game changer, based on the degree of weight loss that patients experience. It's in addition to like blood pressure lowering and cholesterol lowering effects and things like that. And it by far outperforms any of the orals. So it's pretty significant. GLP-1 is a hormone that tells our brains that we're full. So it augments that. It's an agonist that augments that. And of course, it also has some glucoregulatory effects as well. But the patient doesn't need to be or doesn't need to have diabetes. It can be independently used as a weight loss agent. It also helps to slow gastric emptying. And that has a lot to do with the GI side effects that it is associated with as well. So it's a pretty slow titration. Typically, it's like 4 weeks before moving up dose, and you have to even start at like basically a non-therapeutic dose. Some of the rare but serious side effects associated with these drugs are pancreatitis, gallbladder disease, and thyroid cancer. So I don't have one here, but it's on my next slide. You know, everything is bigger and better, right? As soon as something comes out, something bigger and better comes out, right? So after Wegovy, came Zepbound, or tirzepatide, which again is now all the rage. This is not mentioned in the guidelines because it was newer than the last guidelines set, but there is lots of data and it is FDA approved. It too is a GLP-1 agonist, but it has a second mechanism of action as well on the GIP receptors. So 2 mechanisms, higher efficacy, and somehow, I don't know the mechanism, but studies show that it has less GI effects, not none, but less GI effects than Ozempic and Wegovy. So very, very effective. The website touts that 91% of adults taking the highest dose achieve meaningful weight loss. So over 90% efficacy. And that also So that was weight loss, but also improved like every secondary endpoint too. Again, blood pressure, cholesterol, things like that. So it's quite popular. It's manufactured by Lilly. And actually it's being studied for all kinds of things now. And actually OSA is up here, but OSA was indeed approved. So it's now a labeled use for the Zepbound as well. And of course we have good, better. Now we have best coming. So in the pipeline is a triple mechanism, triple receptor drug that just went through phase 2 trials. So this Retrotrutide, which is also through Lilly, is probably going to be seen soon. So it's kind of interesting.
The GLP ones were like intended to be for diabetes, and then they noticed there was a weight loss, or it was like,
That was definitely the first indication. I think that is the process. They saw dramatic increases in weight loss in the patients with diabetes, which is usually a big benefit to that population as well, because they are typically comorbidly obese. Yes, I think that's the progress. I mean, it's possible that this was in the obesity pipeline sooner, but it definitely came out in diabetes first. Yeah. So this is interesting. The third target here is the glucagon receptor. So yeah. There lots going on in the realm of the GLP-1 agonists. Kingsley, did you?
With these medications, the GLP-1s, do they also for life?
Yeah, so we'll talk about, so one of the consideration, I don't feel like moving this thing, but so one of the concerns here is that a lot of anecdotal stuff or post-marketing stuff is reporting that when the patients stop taking the GLP-1s, the weight rebounds significantly. What rebounds back to like baseline levels in a large proportion of patients. And so for example, one of the things that the tirzepatide studies are trying to do is to demonstrate sustained weight loss as an advantage over the rebound, that it's not that it's just with semaglutide, but semaglutide's older, so there's more studies out there. That was the first that people took. So that's definitely one of these issues up here in terms of the rebound weight gain. Another big one is that it doesn't just target the fat cells, but may also target like lean muscle cells, right? Which is not really the cell that we want it to target for weight loss. So that's an issue. I think anybody working in community pharmacy can tell you about cost and coverage issues. First, it started with, there was this war between people with diabetes and people using it for weight loss, and who was more important and who it should be reserved for. That led to shortages. It's been these meds have been ongoing shortage, in addition to having very limited insurance coverage. That then led us into here, higher demand than physically made. So what happens? What was that? Decreased cost? Increased cost. I don't know if they increased per se, but I don't think they decreased any. But what happened is then, when drugs are in shortage for certain periods of time, the law allows compounding pharmacies to make and dispense, not all, but some pharmacies to make and dispense the drugs. So now we have lots of compounded versions of these medications being dispensed. And these pharmacies are not regulate, much less regulated than the manufacturer is, so that's concerning. And there's a lot of literature on like just the overall safety and impurities and concerns about what you're actually getting when you're getting a compounded, compounded agents. That has also led to like a million different online doctors and healthcare workers, and programs that will dispense it on online programs. This could literally be an entire lecture, but you see where things are going. So lots of buzz, and that's why every single day when I get like these, what's going on in pharmacy world, there's something about a weight loss medication.
I don't know, compound.
Oh, go ahead, Kingsley, and then I'll come in.
If compounded products, are they IVs?
They're injectable. They're not IV, they're sub-Q.
Sub-Q, injectables.
Yeah, so Wegovy and Zepbound are weekly subcutaneous injections.
I'm talking about what the pharmacies are compounding. Are they also compounded?
So they're compounding, sorry, it's a good question. So they will get either multi-dose vials or single dose vials and put it into like syringes as opposed to the pens that most of the time they come in. Yeah, I think. I mean, I don't know what all is going on underground, but that's like the cleanest version of compounding, is when they're taking the manufacturer vials, but just divvying it up. And then,
I'm thinking it was really sterile, but now we have the sterile.
yeah, they're not manufacturing the active ingredient per se, but they're compounding. They're taking one form and changing, modifying its formulation essentially. Yeah. And then our next year.
Yeah, I don't know if this is correct. I read somewhere that GLP-1s decrease efficacy of contraceptives.
I've heard, yeah, I mean, I think there's some data for that. I've looked at some things for alopecia, like a lot of patients have issues with alopecia. There's like a lot of, like, because they're so new, we're gonna see a lot more data soon because, like 75% of America might be on these drugs in the next couple of years. And I'm not saying they're bad, I'm not like, it's just, there's just a lot going on in this, treatment space. So I think if you're interested in it, even if you're not, you're probably gonna have some patients, coming to you or questions. So it's something that's definitely rapidly evolving. Yeah, and if anybody, this had just published the other day or just kind of been reiterated literally on the 11th. So the recent word is that they're coming off the shortage. This is super controversial. And so whether or not the compounding pharmacies can continue their practices once it's technically off of the shortage list. So this is just kind of what the FDA affirmed. It hasn't changed its intentions. However, more than likely, even if it comes off of the shortage list, there's going to be they're gonna fight this. This is going to be ongoing for a while because the verbiage says like basically whichever is longer. So like they can keep doing it until it comes off of the list or blah, 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 blah. So, yeah, this is an ongoing saga, I guess. Yet another thing that has another effort on the part of patients, this is really patient driven, and then I think it got back to prescribers, is the concept of microdosing. Microdosing was a term that was really connected to different psychedelics, and now has, I guess, infiltrated pharmacotherapeutic uses of things, but it essentially boils down to taking smaller doses to both minimize side effects, kind of minimize like tolerance. It's supposed to help with that rebound, like supposed to obviously your drug is going to last longer. So basically it's using subtherapeutic doses, but in some patients it works. So that's something you'll see. It has absolutely no oversight. People are just doing it. But now prescribers are doing it because people told them it worked. So yeah, that's where we are. Last but not least is Plenity. Has anybody seen this okay. Oh, really? This is very interesting to me. Again, I think I'm interested because it looks like a drug, but it's not. It's a device. It's a hydrogel, which means you can read it's made of cellulose and some other factors that basically release, like the capsule releases the inner components once it gets to the stomach and mixes with food and water. And then it just expands. Like it gets to your stomach, and then all these like very fibrous components start to expand, make you feel full. And then pooped out, like it doesn't ever leave the GI tract. So there is some efficacy to it. It's a prescription only device. So in theory, the patient does need a prescription. But because it's not absorbed, it's relatively safe. So it is something that is used, and it's also a lot cheaper than the GLP-1s and other things. So that's interesting. The last couple are just like lots and lots of complementary and alternative. If you Google like CAM for weight loss, you're going to get 8,000, supplements come up. Apple cider vinegar is one of the OGs that I still see on the corner of, shelves all the time. Just remember, like, it's very, very acidic, as it sounds like, and that can be very erosive. And then just some others there that, again, if you're questioned for it, you should do kind of your own review. But yeah, so just keep in mind, obesity is a chronic medical condition. It's associated with many health risks, and that's why it is such a target for treatment of. The meds should be an adjunct to lifestyle changes. Surgery is a great option for some patients. But most importantly, there are many roles that pharmacists can play. So I hope that if you go back to that second slide, you realize all the things that you can assist either your patients or your providers with based on your pharmacokinetic expertise. Thanks, guys. There's a quiz that's on Canvas. That's open note, 10 questions. I don't remember when it's due, but okay. So just don't forget to do that. All right, happy Valentine's Day, and I'll see you soon.